Hello, my name is Roger Henderson and I'm a GP, and I also co-host the GPnotebook study groups. Welcome again to the GPnotebook podcast, where we discuss bite-sized topics aimed at all those working in primary care. You can find us on all major podcast platforms, including Spotify, Apple and Google Podcasts. So do please follow us to receive notifications about new episodes, and if you're liking what you hear, do please consider leaving a review to help other listeners find us. Now, in this episode, I want to discuss lower urinary tract symptoms, or LUTS, in men, as this has not only been requested as a topic by a listener to the podcast, so many thanks for getting in touch about this, but which also represents a highly prevalent and clinically significant presentation, particularly amongst our older male patients. Now, these symptoms reflect disturbances in the storage and voiding phases of micturition and can profoundly affect the quality of life of men who suffer from this. Now, whilst traditionally associated with benign prostatic hyperplasia, LUTS in men arises from a variety of structural, functional and neurogenic causes. And in my opinion, a nuanced understanding of the underlying pathophysiology, the diagnostic strategies and individualized management options is essential to providing effective care to our male patients with LUTS, and this is what I want to take a broad overview on today. So, around 30% of men over the age of 65 suffer from potentially troublesome LUTS, and the prevalence of symptoms increases from a few percent in men under the age of 45 to more than half of men in their 60s, and then to nearly 80% of men over the age of 80. Now, around a third of men will develop urinary outflow symptoms, of which the principal underlying cause is benign prostatic hyperplasia. So, LUTS is typically categorized into three groups. There's storage symptoms, there are voiding symptoms, and there are post-micturition symptoms. So storage symptoms involve urinary urgency, increased frequency during the day, nocturia, and in some cases, urgency urinary incontinence. And these symptoms are often linked to detrusor overactivity or other bladder dysfunctions. Voiding symptoms, on the other hand, may include a weak stream of urine, hesitancy, intermittency, the so-called stop-start peeing, straining during urination, and the sensation of incomplete bladder emptying. And these complaints often suggest an obstructive process, such as BPH or bladder outlet obstruction. Post-micturition symptoms, though frequently underreported by patients in my experience, include post-void dribbling and a persistent feeling of incomplete emptying. And these can result from a reduced urethral closure or inefficient detrusor contractions. It's very important to say here, though, that these symptoms rarely occur in isolation, and most men I see with LUTS experience a mixture of storage and voiding complaints. And we should also always remember that the degree of symptom severity does not always correspond to the anatomical extent of the disease, and this discrepancy underscores the need for thorough and individualized assessment. Now, despite the high prevalence of LUTS, as GPs, we all know that many men delay seeking medical advice from us due to embarrassment, misunderstanding the cause, or simply assuming these symptoms are an inevitable consequence of aging and that nothing can be done. Unfortunately, this delay often allows symptoms to progress and increases the risk of complications, such as urinary retention or recurrent UTIs. Now, the causes of LUTS in men are diverse, and whilst benign prostatic hyperplasia remains the most common and widely recognized etiology, it isn't the only contributing factor. In men with BPH, this benign prostatic enlargement can lead to bladder outlet obstruction, either by mechanical compression of the urethra or by dynamic increases in smooth muscle tone in the bladder neck and prostatic stroma. Nevertheless, and I will make this point again, it is entirely possible for men with small prostates to experience very significant LUTS, and for those with large prostates to remain largely asymptomatic. And this observation has helped to shift our clinical understanding away from a purely prostate-centric view. Bladder dysfunction also plays a central role in many cases. Detrusor overactivity, characterized by involuntary bladder contractions during filling, is a very common cause of urgency and frequency. Chronic outlet obstruction can further contribute to detrusor hypertrophy, fibrosis, and eventual underactivity, resulting in poor emptying and increased post-void residual volumes. In some men, LUTS may arise primarily from detrusor underactivity, a condition that's often difficult to diagnose and treat because it frequently overlaps with symptoms of obstruction. We must also consider other causes here, particularly in men with atypical presentations or who fail to respond to standard treatments. Now, urethral strictures, often due to trauma, previous instrumentation or infection, may present with obstructive symptoms very similar to BPH. Chronic prostatitis or chronic pelvic pain syndrome can mimic LUTS and often include pelvic discomfort or pain during urination or ejaculation. Neurological diseases such as Parkinson's, MS, spinal cord injuries, or diabetic autonomic neuropathy can all disrupt the coordination of bladder and sphincter function, leading to both storage and voiding difficulties. And in addition, behavioral and lifestyle factors such as excessive caffeine or alcohol intake, fluid overconsumption, or the use of medication such as diuretics and anticholinergics can all exacerbate symptoms here. So, we must always take care to do a thorough clinical evaluation when trying to determine the underlying cause of male LUTS and to guide our subsequent treatment. And this initial approach should always begin with a comprehensive medical history that explores the duration, severity, and progression of symptoms, as well as their impact on daily life and sleep. Inquiring into the patient's fluid intake, voiding habits, medications, past urological history, and sexual function is also vital. And if you're a GP who likes to use symptom scoring tools, then the International Prostate Symptom Score, the IPSS, provides a good standardized method to assess symptom severity and to monitor treatment response. Now, physical examination should always include a digital rectal exam to assess prostate size, consistency, and tenderness. In some cases, signs of neurological impairment may be present, and these should always be evaluated as a matter of some urgency. Urinalysis should be a standard part of any workup here to exclude a UTI, hematuria, or glycosuria, and PSA measurement is appropriate in men where prostate cancer screening is being considered or when the prostate volume needs to be estimated indirectly. And PSA levels may also guide our decisions about medical management with 5-alpha reductase inhibitors. Now, we can sometimes forget that using a bladder diary, where the patient records the timing and volume of their fluid intake and urination over several days, can be really helpful, particularly in cases of nocturia or polyuria. Post-void residual volume, typically measured by bladder ultrasound, helps assess the efficiency of bladder emptying and to detect retention, and uroflowmetry provides information on urinary stream strength and pattern, although these results can vary significantly. In complex or refractory cases, urodynamic studies may be needed to differentiate between obstruction and detrusor dysfunction, but cystoscopy or imaging studies, such as ultrasound or MRIs, are typically reserved for patients with hematuria, a history of malignancy, or any suspicion of structural abnormalities. Now, looking at treatment of LUTS in men, this should always be personalised. It is never a case of one size fitting all here, and should take into account symptom severity, patient preference, prostate size, any risk of progression, and the presence of any complications. Now, I would always refer a man with LUTS for a specialist assessment if they've got bothersome lower urinary tract symptoms that don't respond to conservative management or drug treatment, or if they're complicated by recurrent or persistent UTIs, or if there's stress, urinary incontinence, or renal impairment due to lower urinary tract dysfunction. Now, obviously, urgent referral criteria here includes acute retention, possible malignancy, visible hematuria, and culture-negative dysuria. Now, my approach to men with mild symptoms and low levels of bother is often that a watchful waiting approach may be appropriate, and this involves lifestyle modifications such as reducing fluid intake in the evening, avoiding bladder irritants, managing any constipation, and voiding at regular intervals. And these simple strategies may be sufficient to prevent progression in a subset of patients. If symptoms are more pronounced or bothersome, then drug treatment is typically first line with alpha-1 adrenergic receptor antagonists, such as tamsulosin and alfuzosin, being commonly used, and they act by relaxing smooth muscle in the prostate and bladder neck to help improve urine flow. Now, these agents offer rapid symptom relief, but we must remember they don't reduce prostate size and they don't slow any disease progression. And their well-known side effects can include dizziness, postural hypotension, and ejaculatory dysfunction. In men with demonstrably enlarged prostates, the addition of a 5-alpha reductase inhibitor such as finasteride or dutasteride may also be beneficial, and these agents reduce prostate volume and PSA levels by inhibiting the conversion of testosterone to dihydrotestosterone. Their effects can take several months to become evident though, but they can reduce the risk of urinary retention and the need for any surgery. Combination therapy with an alpha blocker and a 5-ARI has shown superior efficacy in reducing symptoms and preventing progression in men with moderate to severe LUTS and enlarged prostates. For patients in whom storage symptoms such as urgency, frequency, or nocturia predominate, particularly when detrusor overactivity is suspected, then treatment may also involve the use of antimuscarinic agents or beta-3 adrenoceptor agonists. Now, while effective, these medications require caution in men with high post-void residual volumes because of the risk of retention. Now, in some cases, these can be combined with alpha blockers to address both storage and voiding symptoms concurrently. In patients where anticholinergics are ineffective, can't be tolerated, or are contraindicated, then mirabegron, a selective beta-3 agonist, can be used second line as well. Another pharmacological option includes phosphodiesterase type 5 inhibitors, such as tadalafil, which have demonstrated modest improvements in LUTS and may be especially beneficial in men with concomitant erectile dysfunction. Now, as we know, this class of drugs enhances smooth muscle relaxation in the lower urinary tract and may improve overall urinary flow and bladder function. But we should not be using a PDE5 inhibitor solely for the purpose of alleviating LUTS. Surgical intervention should only be considered when conservative treatment and medical therapy has failed, or if complications such as recurrent urinary retention, hematuria, bladder stones, or infections develop. Now, transurethral resection of the prostate, a TURP, remains the gold standard surgical treatment for BPH and offers substantial symptomatic relief in appropriately selected patients. But for men with very large prostates, more extensive procedures such as holmium laser enucleation of the prostate, HOLEP, or open or simple prostatectomies may be required. However, newer, minimally invasive procedures such as a prostatic urethral lift or water vapor thermal ablation have now emerged as alternatives for men seeking treatment with fewer side effects and shorter recovery times, although the long-term data of these is still being accumulated. So that was a very quick overview of LUTS in men, and I do hope you found it helpful. But have a look at the show notes that accompany this episode at GPnotebook.com, and we'd be very grateful if you'd consider following the podcast and leaving us a review on your favourite podcast platform. It really does help us. Feel free to get in touch via social media at GPnotebook or email us support@GPnotebook.com if you've any questions, comments, or ideas for future podcasts, as in this case. You should also visit us at GPnotebook.com to register for our virtual GP Notebook study groups, which occur all year round, and to download free shortcuts to help improve the lives of our patients in primary care. But, as always, until the next time, thank you for listening, and goodbye.